Welcome back to PSCRIT and part 2 on pediatric acute liver failure. I'm Zach Hodges.
And I'm Alice Shanklin.
Today we are excited to have back on the podcast Dr. James Squires. He's a pediatric hepatologist from the University of Pittsburgh, the first author on the 2022 Pediatric Acute Liver Failure Clinical Guideline. Certainly very excited to share this message with you.
Yes, and we are so grateful for Dr. Maria Pliakas for recruiting this guideline author for us. Maria is a critical care fellow at the University of Michigan. She's interested in using data science to determine the best way to sedate these patients with liver failure as we bridge them to transplant. We are so grateful that she reached out to us and for her help with this episode.
Yes, let's get right to the content. So we've had a great discussion so far. We defined acute liver failure. We talked about the primary complications of neurologic failure and hepatic encephalopathy. Maria, will you catch us back up with our case and give us our next question?
Sure. So our 4-year-old male patient was admitted to the pediatric ICU with acute liver failure and hepatic encephalopathy, like we discussed. He did ultimately require intubation for airway protection. Over the next few days, though, he developed hypotension refractory to fluid resuscitation and acute kidney injury. He also has worsening of his coagulopathy, requiring multiple blood product supplementation to safely facilitate access with a central venous line and arterial line. And so our next thing that I'd like to talk about is why are our patients with acute liver failure so at risk for cardiovascular dysfunction and fluid refractory shock?
Yeah, I mean, again, it's a multi-system disease, right? It's a multi-system disorder. And, part of it, again, also depends on what's driving this kid. For example, the kid that you're describing to me, without knowing anything about the kid, is kind of the classic, what actually ultimate turns out to be the indeterminate acute failure kid. And what we're learning more and more about those kids is that they seem to have some sort of hyperinflammatory reaction that occurs within their livers that then spreads to the rest of the body. This is why things like, kind of shotgun pheresis and plasma exchange and all that, that's why that works, is that we draw off all this stuff, the good and the bad. But there is some data to suggest that, when you draw down some of these, markers and inflammatory mediators that drive the process, you can kind of cool things off. And so I think it's a complex interplay between all the different organ systems, right? The liver is your wastewater treatment plant, right? It is there to filter out all the bad stuff, all the bad humors, all the things that, the body generally doesn't think it needs or wants. And so when you lose that ability and you have all of these, now again, we don't know which markers do what, right? So I can't tell you that it's, interferon gamma or, IL-6 beta, whatever. We don't know which markers are necessarily driving processes. When you look at the kind of assessment of these kids, blood in general, the inflammatory signals are kind of through the roof all over the place. And there seems to be these kind of feed forward, inflammasomes in some of these kids that really, tends to progress them forward. And so that just affects every organ. That's a SIRS type process, right? I do think one of the things, and, maybe we'll touch upon this later, but you mentioned it, so I'm going to kind of talk about it, right? Which is, the kind of how much support do we give to correct their INR, right? Because this is another area where I have very strong feelings on, in the sense that, everybody will start getting worried when the INR goes above 2 and then 2.5 and then 3 and then 3.5 and then, and it keeps going up and up and up. The natural tendency there is to correct it, right? We've got lots of products that we can give to bring that number down and make everybody feel better. What we actually don't know is what that number really means as it relates to bleeding risk in a kid with acute. Because when your liver fails, you lose both your pro and anticoagulation factors, which the liver makes both of. And so when people have actually done kind of, the kind of more complex studies like TEGs on these kids, they actually find that they're generally seem to be in some sort of kind of hemostasis, right? They're kind of in, a place where they, at least as far as we can tell, they aren't necessarily at risk to bleed. And we actually see that, right? We have kids, usually babies, but, kids with portal vein thrombosis. And so, what I definitely try to caution, my ICU colleagues about, particularly the fellows, right, who are doing stuff overnight because, they're excited and they want to kind of do the best they can, is that I don't really care about a number. I don't care if the INR is 2 and I don't care if the INR is 6. If it's 10, I care. But I will let that INR drift unless you're putting in a line or the kid is starting to have some bleeding from some tube somewhere, or they have a history of a bleed because they're, a little neonate who's got a head bleed. Then I don't necessarily think that we should be correcting numbers just to correct numbers. Because what you do in that child is you just give them a whole lot of product, you flood them with fluids, you overload them, then they can't breathe, then you're intubating them, and then you're running into problems, down the line. And so when we have these kids, who have acute liver failure, I really try not to necessarily overcorrect the numbers. Again, short of doing a procedure or having active bleeding, I really try to sit on them and see where that number is going to go. Because A, I think it's helpful for me to know kind of how sick this liver is. But B, I think, giving product just for the sake of giving products just gives them extra fluid that they don't need. And we already talked about, we kind of want to keep these kids on a little bit of the drier side of the mark. And so that's like a lot of people, don't always hear.
I was going to say, I think it's such an important learning point that the level of derangement of INR doesn't necessarily in a linear way predict the risk of bleeding. And these kids can also be at high risk of clots. And if I understand correctly, perhaps you're using the INR as more of a prognostic indicator than you would a coagulopathic marker. Is that fair to say or no?
Yeah, I guess, right? I mean, it's my window into how this liver is actually functioning. That's, I think, the easiest and most concrete way to know how the liver is doing, right? Again, maybe prognostic markers is a question down the line, right? But, there are a few prognostic markers that are out there. The challenge with all of them is that they are, most of the time, one point in time, right? Or it's been done on like a retrospective database. And so, the question when you talk about prognostic markers with acute liver failure is what do you use, right? Do you use the admission numbers? Do you use the peak numbers? Right. So in some of the markers, it's like, they've gone back, they've looked and they said, oh, yeah, I use the peak INR, I'm able to predict it with it. Well, yeah, I didn't know it was the peak, right? That day, I didn't know it was that day. It was just another number. I didn't know if tomorrow was going to be higher or tomorrow was going to be lower. Another problem with these is that, again, we're mucking around with a lot of them, right? INR, people are giving products and correcting. Something like phosphorus, hopefully people are giving phosphorus to get the phosphorus out, right? So that kind of falls away. Encephalopathy, incredibly challenging to assess on a kid. The ones that seem to keep coming out in the wash, though, when you look at them, INR, encephalopathy, and bilirubin. Those are the three that I think if you look at most prognostic scoring systems seem to come back over and over and over again. So those are the three markers I'm watching pretty carefully. Again, encephalopathy, challenging. A lot of times you lose your exam because the kid's sick and intubated. Bilirubin, important. And then INR, again, I try not to overcorrect because I want to actually see what it's doing. We are doing some work, and actually we'll have a paper coming out pretty soon that actually looked at kind of the change in those markers over time, right? Which I think is a kind of a critical component of this, right? So that essentially saying you can redo the score every day, looking at the change over the last, kind of 72 hours to kind of relook at if you're heading in the right direction or the wrong direction and kind of what the risk is. And, again, it's kind of obvious. If the bilirubin is going up, the INR is going up, and the encephalopathy is getting worse, you're going in the wrong direction. But I think it's still important to kind of recognize that it's not so much one number, which is what a lot of the scoring systems have done in the past, but what are these numbers doing over time?
What's a bilirubin that gets your attention?
It's change over time. It's a rise, right? So it's not a single number. This is where if the kid comes in and his bilirubin's already 4, again, I don't know where he was or, how long this has kind of been going on. If it goes 4, 6, 7, I'm getting worried, right? The same thing is that the bilirubin is normal when the kid comes in and it goes 1, 2, 3. Again, it's the change in all of these things over time that gets my attention.
Maybe one more point about coagulopathy. We always want to limit fluid overload in these kids. Do you, in your practice, implement maybe a TEG or ROTAM, scheduled checks and maybe use that to guide replacements?
We have. We definitely, have started getting a lot more TEGs on these kids. There's actually some data that's coming out with, TEGs in kids, delivered transplants where I still try not to overcorrect even for abnormalities in the TEG, right? Because, I just think it's a complex environment. We need to be more thoughtful than just correcting them, and so I would never stand in somebody's way who felt like, hey, look, I feel like I need to give this kid platelets. I need to give this kid cryo. I need to give this kid fibrinogen because I'm seeing something, right? They got a little blood from the ET tube, or his urine looked a little red in the Foley, or, I think maybe later I might have to do, an art line, but not now. It's okay. You need to have that conversation. Everyone needs to recognize that, look, we're not just doing this because I'm seeing a bad number. I'm doing this because I'm seeing a bad number and I'm anticipating something may happen in the ICU where I'm going to want that number to be in a better place than it is now. That is fine. And that's a conversation that should occur 3 times a day in these kids. But I think, what I try to avoid is just saying, whoop, I got a lab back. I need to give this because I see that the number's low. Because, that's the kind of thought process that I think ends up hurting these.
I have a follow-up question that has to do about the fluids that we're giving these patients, but not necessarily about the coagulopathy piece. We talk a lot about albumin replacements, and what's your thought on using either 5% or 25% albumin in these patients, again, considering they are getting a lot of fluid for other reasons?
Again, if you have to give albumin, I would prefer 25% because, again, it's just less volume than 5%. If you have to resuscitate them for some reason because you feel like they need fluid, then that's when you give 5%. But I think if you're just giving it because the kid has ascites, the albumin's low, and you're wanting to try to manage that a little bit, then I think 25% gives you a lot more.
And tell me about maybe some more of the fluid and electrolytes complications. I hear about this hepatorenal syndrome. Is that actually a player in acute liver failure in kids?
I don't think we know, right? I mean, hepatorenal syndrome is a beast unto itself, right? And, I think a lot of people will say hepatorenal syndrome because it's, because they see the creatinine bump a little bit. But so, by definition, it really shouldn't be something that happens in the acute setting, right? I mean, I think that's really something that is more, kind of chronic liver injury, kind of physiology, at least what we know. That said, if we have a kid who we don't really know what's going on, maybe we didn't get a liver biopsy on, these processes could have been going on for a very long time. And so there is a chronic nature to it that is underappreciated in their acute setting. Clearly, renal injury in these settings is problematic and is something that should be very concerning when you're developing really any extrahepatic manifestation, whether it's cardiac instability, decreasing renal function, obviously getting intubated. All these things are of a concern. But in its truest sense, do I categorize that as hepatorenal syndrome, truly acute liver failure kid? I don't.
And the mental model that I feel like I bring to the bedside with many of these sick patients with acute liver failure who have hypotension is one of vasodilation, like splanchnic vasodilation. The creatinine's going up. They look fluid overloaded. So I tend to have a mental model that favors vasopressors, maybe vasopressin, norepinephrine. Is that a mental model that you feel like you bring to the bedside for these patients, or do you have other critiques?
This is where I lean on my ICU colleagues. I'm not a critical care doctor. I don't necessarily see that as my role is to dictate, which vasoactive medications you feel are going to be best for the patient at the bedside. I mean, yes, everything you said is true, right? But I still think that, one of the great things about being at an institution like Pittsburgh and like many of us are at, right, is that you have great colleagues that you can lean on. I don't walk into the ICU and out of the way, everyone. Like I'm here now, so listen up. This is what we're doing today, right? I mean, this is you have these conversations with your critical care docs, and they have experiences caring for these kids that are unique and that we need to incorporate. If you look at the guidelines paper, it's a great paper. It doesn't contain one single ICU doc on that paper, right? And so I think there are sometimes missing voices that are important when we think about these very complex kids. And in the ICU setting, I think that, the discussion on vasoactives, the discussion on, which medicines to give for pain control and sedation, these are things that I think you need to have individual discussions, looking at the kid in front of you, recognizing, what is maybe in store with that kid that day with the ICU team, and come up with a plan that everybody is comfortable with. But, to kind of dictate exactly, which medicines to use and which ones to avoid. And I just don't think it's that black and white in these kids. And I think, you need to be a bit more thoughtful about it. And I think that's why if you read the guidelines, you'll see that there's a lot of kind of hedging and hemming and hawing and kind of, we suggest this and maybe there's some data that points to that. But there's almost nowhere that we say you need to do this other than get the kid to the ICU if you're worried about a transplant, transplant center. Because there is just so much gray area and so much discussion that needs to happen between the multiple teams that are caring for this. So that was another hedge for you, Zach.
Well, I think it really just gets to the heterogeneity of some of these patients. And, some of them might have this predominant feature of vasodilation and fluid overload. And, some might be septic and have cardiac dysfunction. And having a multidisciplinary team will certainly supersede any kind of general principle that we take to the bedside.
So these patients, when they're in front of us and they're in shock and we're giving them fluids, we're leaning on our vasoactives, vasopressin or norepinephrine, or the thing that often comes to mind too is there's a chance that this patient is septic, and what antibiotics should we be adding on board? And specifically, institutionally, we might be leaning on antibiotics specific to our hospital, but what bugs should we be covering?
And Maria, I'll say a bit of a caveat. Jim, will you tell us more about the significance of immune dysfunction in these kids with acute liver failure? Can we treat them like our other critically ill patients who maybe we assume to have an intact immune system, or not necessarily?
So, to the antibiotic question first, right? So, no real studies show that antibiotics make a difference, in these kids' clinical trajectory, right? But no one's going to fault anybody for getting the kid on a rule out, particularly when they're walking through the door. But if the, cultures are negative, there's no real reason that we should continue antibiotics just indefinitely. as it relates to, infections, obviously, bacterial infection is a pretty rare cause of acute. And most of the time, if it's going to be, infection source, it's going to be a viral in there. More to Zach's point, should we be worried about immune dysfunction in these kids? The short answer is not really, right? I mean, in chronic liver failure, we talk about kind of some immune dysfunction because, of the liver and its immune properties. In the acute setting, we really, I don't typically at least think of these kids as being immunosuppressed. Now, that said, I think we touched upon a little bit this kind of concept of the indeterminate acute, which is an area of intense focus because, it still constitutes about a third of the patients that we see when we look at most, registry databases. Now when we say indeterminate, right, there's probably some of those kids who just didn't have a complete workup, right? Or some of those kids that, got better before we needed to complete the workup, or some of those kids who got transplanted before the workup got completed. And so I think we need to be a little bit careful. I think there's, kind of two, one paper that's just going to be coming out in hepatology, and then I think, another kind of school of papers that have come out recently that I think has kind of whittled down the acute liver failure patients even more. And it really kind of puts them into two buckets. One is the kind of neonatal acute liver failure, or those less than one. And in those less than one, it turns out that probably about 40 to 50% of the time, there's a genetic reason why these kids have acute liver. And there's various genetic causes that we can talk about. But I think for the purposes of this podcast, I'd say if you've got a kid with neonatal acute liver failure, genetics should be moving up as far as kind of, what you're sending off in these kids. Because I think there can be some really important information that comes back as to whether transplant is contraindicated or not in some of these that have a genetic basis. But then the other kind of bucket of kids is what is now kind of being called CD8 T-cell hepatitis. These are kids that have previously been described as having indeterminate acute, that on biopsy have a pretty distinct phenotype of CD8 T cells in their liver. There's also some suggestion that the T cells are in the kind of outside the liver in the blood as well. But that these kids who have this phenotype may respond to immunosuppressive therapy. Right, so this is, again, whether you want to call it the seronegative autoimmune kid, although, that's a terrible definition, right? Or that, kind of hyper-inflammatory kid that's in the ICU where they're like saying, should we give steroids or should we not? I think we've all probably had some of those kids, and that is because there is some emerging data that there does seem to be a hyper-inflammatory signature in some of these kids where immunosuppression may be beneficial. Here, actually, we do have ongoing work. There's an NIH-funded clinical trial called the TRIUMPH study. That I think many of our centers even may be participating in, even if you don't know it, which is looking to enroll these kids with indeterminate acute liver failure. And it's a 3-arm study that's given a placebo versus corticosteroids versus ATGAM, or a CD8 antibody, to try to understand what the role of immunosuppression is in this very kind of unique sliver of pediatric acute liver failure, but one that I think we still don't have definitive treatment for, right? Because in the rest of the kids, for better or worse, right, you're able to figure out what the process is. Then there's a question of, can I treat it or not? If you can't treat it in a timely enough manner, do you need to transplant them before the liver, kind of dies out? The indeterminates is what kind of, gives everybody stress because you don't know. If I just sit on this kid, is he going to get better, right? He may, because I don't know what's driving it. I haven't figured it out yet, and so I can't give anything to stop it. But the kid still may recover, kind of spontaneously and not need a liver transplant. Man, I'd sure like to save him from a transplant if I can. So, to answer your question, I don't generally consider these kids immunosuppressed. The role of antibiotics is really as a rule out and then done if they don't have anything growing because, bacteria really, now again, you can get secondary sepsis, but, again, you should have a culture that's got a guiding therapy there. And then, the role of the immune system in some of these conditions, particularly the indeterminates, is evolving. And hopefully soon we'll have some, better data to suggest, which immunosuppressive medicines may be, able to kind of turn these kids and save them from transplant.
I wanted to point out that I really appreciated the age-based diagnostic approach that the guideline included. And when we have a kid come in with acute liver failure, we print this off, and me and the resident or APP, we go down, we check off all the boxes, we chat with our hepatologist. Which of these are we going to send off today? And for one, just thank you for that. And then the question is, do you see any new or changing diagnostic strategies for these patients? Do you feel like there's going to be a role for maybe like a gene panel or a cytokine panel to try to better characterize the immunologic milieu of these patients to guide therapy?
I hope so is the answer to that, right? Because that's what's needed. For sure, right? There's been a lot of talk about the gene panel. And again, I think there will be a gene panel for the neonates. I think that should be coming. Well, to be perfectly honest, right? I mean, it's going to be whole exome, right? I mean, a whole exome is becoming just as quick and and almost as cheap as kind of some of these targeted gene panels. So whether or not somebody comes up with a panel or not is one thing, but exomes will be kind of in the near future, and that'll be particularly again for the neonates, where I think there's really a lot of genetic linkage failure. For the older kids, that's essentially what we're trying to do with these kind of cytokine profiling of the CD8 T cell hepatitis. And I think more work would need to be done to kind of come up with the definitive panels that we want to kind of look for. We'll see what the study shows. That's in part what this entire TRIUMPH study is looking to do. So in addition to treatment, it's also obviously biobanking. So we should hopefully we'll have a lot more blood and tissue samples to be able to assess, what is really there that is unique about these kids. Because if you look at, for example, the pediatric acute liver failure study group, it enrolled about 1,000 kids in that study, and about 40% of those kids were indeterminate in that study. Now, that number changed over time, and in the last 5 years of the study, it was closer to 30% because we got better at diagnosing. But all that is to say is that when I go to the biobank and say, hey, I want, 500 indeterminates to kind of look at and see, I don't have 500, 200 indeterminates to look at, to kind of study them. In some of those quote unquote indeterminates that were categorized in that study, they probably weren't indeterminate, right? They just didn't have the full workup, as I kind of talked about. So this is why we're trying to kind of reclassify some of these kids, not necessarily as indeterminate, but as this kind of CD8 T cell hepatitis, so that we can understand a little bit more the inflammatory milieu. And now that's just the indeterminates. There's also just kind of data in general, right? Does the liver reach a tipping point, right? Just take Tylenol, for example, right? Why is it that some Tylenol kids still need to be transplanted? Right, there clearly is a tipping point where NAC isn't going to work anymore. The liver is too far gone. And so trying to understand what that cytokine profile is would be of interest. But I think, then you're kind of starting to get, is there one cytokine profile for all acute liver failure, or do you need to be disease specific? It's kind of complicated on how best to study that.
All right, so we've touched on this a few times, but we've got this patient in the ICU. What's the general thought process for choosing to list a patient for liver transplant versus continuing the supportive care and really hoping that things will come back?
This is an age-old question, right? And I know we've kind of touched upon it a little bit, and it is not easy. Like most of this podcast, I don't have a clear answer for it. Mm-hmm. We published on this a little bit in hepatology, looking at kind of the listing characteristics of PALF and kind of what goes into listing a kid versus not. And what's interesting is that the vast majority of kids, if they get listed for PALF, it happens in the first 24 hours after or at least after they enrolled in the PALF study, right? So it seems to happen quickly. Now, we actually tried to capture why is that in some of the later phases of PALF by having this very kind of complex questionnaire that we asked attendees to fill out, each day. Kind of said, did you list, didn't you? Why did you? Why didn't you? To try to get at that nuance. And at the end of the day, the data it wasn't strong enough. And so, unfortunately, I think a lot of this still comes down to how the team is feeling about the kid that day. What I would always say is list early before the kid becomes too sick. So if you're thinking, should I list this kid? List him. Because I think that you definitely don't want to be saying, man, I wish I'd listed him yesterday. Because that absolutely can happen in these. That said, right, we know that before transplant outcomes were binary. You lived or you died. That's what happened. You introduce transplant, into the mix, right, and you have a substantial number of kids getting transplanted. But clearly, within that transplant population are kids that would have lived, right? Transplant hadn't interrupted the natural history of this disease course. And what you're asking is, how do we determine who that is? How can we tell who that is? And I just think, unfortunately, we are not good enough yet to be able to do that. We kind of already touched upon it multiple times, right? But INR going up, encephalopathy getting worse, bilirubin going higher, seeing evidence of kind of extrahepatic manifestations. These are kids that I would definitely think to list sooner than later. Some of it also comes with just kind of experience of seeing these kids over and over and over again and trying to kind of get a sense of, do I think this is a recoverable injury or not? And that's a terrible advice to give somebody. Just trust your gut. But I think there is a sense of that for individuals with this disorder because we don't have the greatest prognostic scoring systems yet. But I would rather, how would I say this? I don't even know if I want to say it this way, right? But I guess I would rather accidentally transplant a kid who might have lived than lose a kid, right? I just think that if we have an intervention that can save a kid's life in the absence of knowing exactly what's going to be best for this kid, I'd err on the fact that I'm going to try to save his life.
And I think one of the most challenging aspects of this is that there's a significant proportion of your patients who you consider for liver transplant, you don't have a diagnosis on what's driving their liver failure. I would like to know a little bit about how does either having a diagnosis or not having a diagnosis affect your decision to list or not?
Oh, I think it's critical, right? Now, that said, we would never not list because we don't have a diagnosis. And mostly the diagnosis is helpful for those where transplant is contraindicated, to be perfectly honest. And again, now we're kind of talking about mostly neonatal ICU kids with mitochondrial disorders, and some of these other kind of rare genetic disorders where liver transplant doesn't cure the disease, right? Although acute liver failure may be their presenting phenotype of their disease, transplant's not going to cure them, and they're inevitably going to have multi-system involvement, of their rare genetic disorder. In that instance, and again, going back to the neonates and the genetic gene panels that I think are going to be critically important in that stage, I think knowing that information is really, really important. And still, it's always nice to have a diagnosis because, you want to make sure that whatever, you're putting in a new liver, that it's not going to come back. There's few of those in the later years, but it also kind of helps as it relates to kind of some of the immunosuppression that you might use or how you would manage their post-transplant course if you knew they had a certain condition or not. So, I think having a diagnosis is really important, but, still, despite our best efforts, and this is, I'm looking at the kind of the last phase of PALF, which was the last 5 years of the study, 30% of the kids, despite having, very regimented kind of way in which we work these kids up, which is presented in the guidelines, didn't yield a diagnosis in these. And in those kids, some of them, they've actually tried to go back and adjudicate, so give us a bunch of samples and we'll run all the tests and make sure that they still can't find a diagnosis. And so indeterminate is still going to happen. And it's probably still going to happen more often than not. And so, I think still being prepared to list those kids for transplant is important. And most of those kids after transplant do just fine. I would not use an indeterminate diagnosis as a reason to delay listing or not to list.
Yeah.
Nice. A follow-up question on that. You mentioned the neonatal ICU. What's your size criteria for listing someone for transplant? And then what's the turnaround?
Well, yeah, so we don't have a size criteria here, but I think that's going to be institutionally dependent, right? So we will transplant the, little tiny galled babies. I should say, we will list them and transplant them if we can, but because the turnaround becomes much longer when you're a neonate because, you can't just, luckily there aren't a lot of healthy neonates dying. And even if you were doing split transplants or living related donor transplants, my left lateral segment is not going to be able to be fit into 3 kilo infant. And so essentially you're looking at like the left lateral segment of a 2-year-old or something, right? So I think the logistics of that become much more challenging. And again, I'm sure you could have a whole podcast on living, on organ allocation, and the complexities of all of those things. But we will list a child at almost any size if we think that they have a transplantable condition that once we list them status, they go up to status 1A as a pediatric acute liver failure. For the older kids, that generally goes pretty quickly, right? They'll start getting offers right away. Now, again, depending on how sick the kid is, you can kind of still might want to be a little bit choosy about which organs you take if you feel like, you don't necessarily need to jump at the first high-risk donor. But the smaller kids, sometimes, even though they are 1A, will sit on the list for a while because you need to really match as much as you can by a size that's going to fit. And so I think that they can linger on the list for a while. They can die on the list.
Maria, I want to give you the floor at least one last time and see if you have any follow-up questions.
I don't think I do. Thanks.
Wait, I have a question. What happened to our kid?
Oh, do a little case wrap up here.
Are we going to return to the kid?
Our 4-year-old was admitted to the PICU where we consulted Dr. Jim Squires, got very excellent hepatology and critical care, and was determined to have indeterminate liver failure, was listed for transplant, successfully transplanted, and now he follows up hepatology clinic, Dr. Squires' clinic, and stays well far away from the PICU.
And hopefully in the future we'll be able to say that kid should have gotten steroids or T-cell depleting antibody, and I would have prevented him. That's my goal.
Well, I really appreciate both of our guests, Dr. Jim Squires, Dr. Maria Pliakas, for joining us today. This is a great topic. It's a messy topic because it's imprecise. It's a heterogeneous group population. These kids are so incredibly sick. We really appreciate the multidisciplinary care that these patients have to receive. And we really appreciate you, Dr. Squires, for giving your time, leading our discussion. We're very excited to share this with our audience.
Zach and Alice, I can't thank you enough for the invitation, and hopefully people learn something. But I think you said it beautifully, right? Which is this is a multidisciplinary syndrome. It takes transplant surgeons, nurses, critical care staff, hepatologists, nephrologists, neurologists, geneticists, infectious disease docs. It's an all hands on deck experience. And so everybody's coming to that through the lens of their subspecialty. And so even though mine is as of a liver specialist, again, I think that we all have a lot to learn from each other as how best to do this in the future. And so I look forward to working with, you guys and the rest of the critical care community to kind of help think of new innovative ways to manage and treat these conditions.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review on your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.